Brilliant. Okay, well, thanks very much. It's good to see everybody, sort of metaphorically. And I thought, following the sort of final DDRB arrangements in terms of the financial package that's available for practices this financial year, it would be a good idea to summarise what's available, summarise some of the background as well in terms of how we get to where we get and what sort of changes might be in the pipeline going forward. Really this was designed to sort of cover a lot of queries that people might have. Obviously, yes, as Sarah said in the beginning, please put questions in the chat. Chrissy and some of the other directors are around. But I will try and pick them up. There may be questions you ask that are coming sort of further, so just to sort of help, this is what I'm hoping to cover during this presentation. We're scheduled to go on till I think 2:30, but so because I don't want there to be any rush and I want to be able to answer questions as we go through. Obviously, I thought I'd better say at the beginning, although this presentation is simply on financial reimbursements, I'm absolutely sure that everybody's sort of seen a lot of publicity about changes planned for the 1st of October, and there will be quite a long update in the form of FAQs coming out from the LMC this afternoon, and also going onto our website and into some of the sort of WhatsApp channels we've got, which covers a lot of the questions that colleagues may have about what might happen or might not, what might not happen on the 1st of October. And I think I should say in advance of that is that although I've covered as comprehensively as I can what we know at the moment, it may well be that there'll be other sort of developments over the coming weeks. But that will be coming out this afternoon, and I hope that's sort of helpful for everyone as well. I should say also there will be additional information from GPC England. And by an enormous coincidence, some of it might look like what you read from the LMC this afternoon. So what I wanted to do was to, first of all, obviously we started off in April with a contract agreement with the financial sort of arrangements that came with that. We knew that there would be a DDRB recommendation, and I'll go into that later, which would affect the final sort of financial arrangements for practices this year. But essentially, as I sort of sent out a number of letters in April, essentially we tried to focus on global sum because that's your core and primary income in terms of your capitation payments. Obviously, NHS England are very wedded to the ARRS scheme, so there was an uplift related to that as well. Advice and Guidance, a new scheme that really we're getting some quite positive feedback from locally. And if you remember, Advice and Guidance, a National Enhanced Service, that is only available this year, but we would like to negotiate its continuation. And I think given the work that ICB colleagues and also GP colleagues and even NHS England have put into it, a lot of the teething in terms of Advice and Guidance have been overcome. So it would be a pity if it all ended on the 31st of March next year. So we're hoping that will feature next year. The other things that we looked for in the negotiations were the Statement of Financial Entitlement uplifts, which I will cover, and vaccinations and vaccination item of service fees, which was probably, to be honest with you, the most difficult part of the negotiations in terms of getting an uplift, and we didn't get the uplift that we were looking for. We got about 2/3 of the way. And that is going to be a feature of the coming year's negotiations as well. But overall, probably, the QOF transfer was the most controversial aspect of that. We do understand that QOF changes and QOF transfer of money have winners and losers, and that was carefully looked at when we actually discussed the contract outcome. But in all, the underlying aim was to maximise your global sum income. Now, some people, you often see references from me to the DDRB. The DDRB is one of the longest standing quangos that in the UK, and it's been going over 50 years. And the problem was that in the 60s and 70s, the issue of doctors' pay, and to a lesser extent dentist pay, but primarily doctors' pay, became extremely politicized. And on the other hand, it was felt that that's not appropriate, that medical professionals should have or should have confidence in the government being independent and impartial. I know it sounds rather sort of naive nowadays to say that, but that was the thinking in the 70s. And so the DDRB was set up so that it could look at what doctors should be paid in an independent way. Now, of course, politicians are never going to give up control completely. So although the DDRB operates independently and it makes recommendations based on the submissions from the BMA, obviously the British Dental Association, but that doesn't concern us at the moment, and NHS England, and it covers the entire UK, so separate submissions are made from Scotland, Wales and Northern Ireland, and it makes recommendations that the government can interfere with. Now, during the course of the new Labour government, this year and last year, the government has honoured the DDRB recommendations, which, as you recall, was 6% last year and 4% this year. Now, one of the other things that's happened in recent years is that the DDRB's report has slipped. So it used to come out before the start of the financial year, and obviously then the government would decide, and it could all be sorted out in one sort of go at the start of the financial year. But unfortunately, last few years, its report has been delayed. The Secretary of State recognises that this causes a significant problem for everybody, not just GPs. There's a lot of work in backdating consultant SAS and resident doctor salaries as well. So he has asked that it reports, well, he's called it early, but actually when it would normally report for 26, 27, and we're hoping that they will be able to do that, and therefore there won't be this sort of mid-year rearrangement of the deck chairs. Now, obviously, you'll be aware that during the multi-year deal, during the 5 years of the multi-year deal, there was no recommendation for GP partners within the DDRB, and that's because there was a sort of separate arrangement agreed with the government, which included what the uplift for partners should be. Now we're 2 years now into where there are recommendations for contractors separate to salaried colleagues, and that will continue next year. So there'll be a separate recommendation for both salaried GPs and for partners. But the problem is for salaried GPs, and obviously for other colleagues such as consultants and resident doctors, SAS doctors, the recommendations simply translate into essentially your salary and your terms and conditions of employment, if there are any. But for contractor GPs, we're not employed. We don't have a direct contract with NHS England. And so the uplift for salaried GPs is translated into the payment elements of the GP contract. And as we sort of saw in the last slide, what we've tried to do is to maximise the uplift in global sum. But it's perfectly possible for that uplift to be included in QOF, in PCN DES and SFE reimbursements. But remember, there's two sort of phases to this. The first is the contract negotiations, and then there's the DDRB uplift, but the DDRB uplift only refers to pay. So, for example, quaff is not regarded as pay, okay? And therefore, you won't see the quaff included in any uplifts after the DDRB recommendations. And not all global sum is pay as well. So 84% of global sum can be considered as pay, and we did get the DDRB recommendation applied to global sum, but only to 84% of it. The other component, which is classified as other expenses, aren't pay elements, so that didn't get uplifted during the application of the DDRB uplift. So it is very complicated, which is one reason I had people say to me, this is so complicated, Julius, you wouldn't start from here. And I agree. But this is one reason for doing this presentation. And as Sarah said, this presentation will be available and the webinar will be available afterwards as well, the recording. So you'll be able to think about, well, why is it so difficult? If you're practice managers or business managers, you may be thinking, why is it so complicated in terms of payments to contractors? Even though the DDRB recommendation appears on the face of it to just be a simple percentage, it isn't for contractors, and that's why we have this rather complicated process. Now, the complications of this process are made worse by the Cahill formula. So if you look at bullet point 5, which was to say, yeah, for contractors, we don't just increase their pay, we put it into the contract. Into the contract it goes, but then the Cahill formula is a kind of separate black box between the money that goes in to apply to global sum and what actually gets to you as the practice. Now, many of you will remember the Cahill formula, the introduction of the Cahill formula in 2004. And the idea is that you are paid based on the number of patients that you have, but each patient is invisibly weighted so that they attract a bit more or a bit less money. And obviously you can't see that for individual patients, but aggregated into your total list size, that affects the amount of money. Very few practices come out as exactly one, so you get exactly what you put in. In most cases, practices are sort of between 0.9 and 1.4 or 5 of the raw figures. So your raw figures are the actual true number of patients, and the weighted number is affected by the different characteristics of your patients. And obviously things like age, gender, morbidity, but it also includes factors such as rurality, and there's a element in terms of workforce costs where you live, because obviously those are different in the southeast than they are in sort of Northumberland. So the metrics within the Cahill, if you go right to the bottom, the very bottom of the 150 pages of the Statement of Financial Entitlements, you'll find a link to how the Cahill formula is calculated, global sum is calculated based on the Cahill formula. So it will be obvious to you that if that was introduced in 2004, the negotiations for the new GMS contract took 2 years. So the data that was used to inform the Cahill formula was based on information from the 1990s. Okay, and I appreciate some of you probably weren't even born in the 1990s, and so it's really old, and it is increasingly out of date. And it doesn't include some factors that GPs and everybody who works in the practice realise do affect the workload, because the idea is that the Cahill formula weights your list based on workload, what your list's characteristics mean in terms of the workload that you get. And things like deprivation, postcode deprivation, and English not as a first language, for example, are not included within the Cahill formula. There is a flat rate London weighting of about £2.18 that applies to patients who live within the metropolitan postcodes, but that's remained unchanged since 2004. There's also a sort of recognition by everyone that the Cahill formula needs changing. Now, if we successfully start on the process of negotiating a new GMS contract, then the first thing will be to negotiate the Cahill formula. And there's a huge sort of interest in how we would do that, and work has already started on that in terms of what NHS England have commissioned. And the problem is that everything you do to the Cahill formula is affected. It affects, it's got a sort of knock-on effect, and the only way of successfully renegotiating the Cahill formula without destabilizing practices is to put more money into it, and that is accepted by everybody as well. So looking at the questions, I didn't know the question. The question there, you look too young to remember MPIG, but so basically, for colleagues who weren't around in 2004, the negotiations went on reasonably well. I think most people feel that the outcome in 2004 was fairly positive, but then things have sort of deteriorated since then. But there was a sort of black day in the final stages of the negotiations when it was realised that the changes to the Cahill formula destabilised a proportion of practices. And so what was called MPIG, which is the minimum practice income guarantee, which you've all forgotten about because it's been phased out for sort of 7 or 8 years now. MPIG was introduced to prevent or to give a sort of floor to practice income based on the effect of the Cahill formula. Now, we have absolutely got that as national negotiators engraven on our heart, and is absolutely the case that we're not going to end up with a sort of MPIG day in any future negotiations about GMS contract. And I think it was a lesson that all of us learned. To be fair, nobody anticipated it, the destabilising effect of the Cahill formula to such an extent at the time, but it just shows you the importance of modelling. So we still believe that the government is committed to a GMS contract renegotiation. I know it's difficult sometimes to sort of be confident about what politicians are anticipating, but if we do, then the Cahill formula negotiations will be a key part of that. But I just wanted to discuss that in detail because the problem is that you think of a recommendation from the DDRB, you look at the government and see what it says, you then translate that into elements of the contract, pay elements of the contract. So I've showed you here the three income streams that go into global sum. 2 of them are pay. I mean, obviously, GP contractors, it's profit, but it's called pay for the purposes of this calculation. Then you have other staff expenses, including on costs and your salaried GP colleagues. And then you have other expenses. And the pay element was 84% of global sum. Now, these elements are not sort of conjured out of the air. These elements are based on HMRC data, anonymous HMRC data, in which the income and expenses of both salaried GPs and contractor GPs is looked at. And later on in this presentation, I'll be looking at the latest GP earnings and expenses report. The problem with this is that it's in arrears. So when we look at the costs that the HMRC identifies and NHS England puts into the Cahill formula calculation, sorry, I apologise, into the global sum calculation, then you can see that they're based on figures that are 2 years out of date. So when we look at the 2026-27 contract negotiations, we will be using the 23-24 earnings and expenses, which have just been published. So that was quite a long bit of my presentation, but I wanted to sort of say to colleagues, this is not a simple process. There's the big blue block showing global sum uplift, but how we get to it in terms of contractors is complicated, and that's because contractors, we are not, we don't have a sort of simple salary at the end of the day. Now, for GP salaried GP colleagues, what happens is that the BMA puts the BMA have a salary scale, a salary range for sessional GPs, and they just apply the uplift from the DDRB recommendation. And I'll come on to that as well, because I know that's another sort of topic of conversation and questions that the OMC office gets about salary GP pay scales or pay ranges. But you can see, compared with the last 10 minutes description about global sum and the Cahill formula, you can see that applying it to employees, all you do is just increase their salary. And to be fair, that's why it's much more difficult for GPs, contractors, to feel that the headline figures are necessarily what they get when they look at their monthly incomes. So in terms of the query about COVID has now worked its way through the sort of income and expenditure. So when we looked at the COVID vaccination programs, the first 2 years particularly were sort of extensive vaccination programs, which artificially changed payments that were made to practices. By saying artificially, I mean they changed them in time, but just during those 2 years. That has now worked its way through what we're expecting to deal with going forward in terms of negotiations. But it certainly was a problem, because it was created an artificial income, but then it created an artificial set of expenses as well, and no one was clear whether the income and the expenses properly, the ratio between the two, was appropriate. And we certainly didn't think the item of service fee for COVID vaccinations was appropriate. Right, so I've been through all that. So basically, when we look at the DDRB 4% recommendation was 4%, but for everybody, the public sector pay assumption for this year was 2.8. And when the 25-26 contract was negotiated, that was a sort of non-negotiable element or component of the contract. So for the purposes of the government, you have already had 2.8%. So the uplift was 1.2%. Now, obviously, that, I know that's challenging, and I know that the effect on minimum wage, the payments for the minimum wage, has affected things as well, and so has national insurance. But we will come on to look at some figures later on that will sort of put that into context. But I hope that this explains why the headline figures that you read and the actual income you get as contractors, it's really, really difficult to join the two together. And that's because of all these interposing problems. So if we look at the uplifted elements of the contract, I've discussed with you GP contractor income, other staff expenses, including salaried GPs. Now, we were able to get a further uplift in terms of the statement of financial entitlements, and we got them to look at the ARRS allocation as a pay process. And for GPs in ARRS, they uplifted that element by 4%. Now, you are you are aware that obviously now there isn't a separate GP element within ARRS because it was sorry about that. It was incorporated or subsumed into the total allocation. So you could theoretically, if you were a new PCN starting on the 1st of April this year, you could use all your ARRS allocation on GPs. So there isn't a separate element there, but we nominally doubled the amount we doubled the amount that was available last year, because it was 6 months last year and 12 months, and we increased that by 4% and then put it into ARRS. For Agenda for Change, the pay uplift, the national pay uplift was 3.6%. So the uplift that applied to ARRS element, which is covered by Agenda for Change, was 0.8%. And we also persuaded them that paying for enhanced access was essentially paying for staff, so that should go up by 4% plus the on costs as well. Right, so let me move on to the next slide. There were other increases that could be were not considered to be pay. So obviously things like vitamin service vaccination fees, QOF, what's left of the IIF scheme, they were not increased by anything or not increased further, I should say, as a result of the DDRB recommendation. Only those elements within the DDRB that, only those elements within the contract that could be considered pay were uplifted further. So the question that's just been asked, was the whole PCN budget increased by 4%? No, only those elements of it that could be considered pay elements were uplifted. And in terms of ARRS, that's GPs nominally at 4% and 0.8% for Agenda for Change. So not the whole element, just those elements that you could call pay. And going back to my earlier slide, which I showed you as well, DDRB recommendations relate to pay. So we have to work out what element of the contract, of the global sum, refers to pay. And in this year, it was 84% of global sum. So that means that the global sum has gone up by another £1.50, and the total uplift for this year is £10.84, which is 9.64%. Obviously, the out-of-hours deduction is unchanged. So if we look at what's happened to global sum over since 2004, and this is based on CPI inflation. So this isn't obviously absolute figures, which are not really very helpful, but on cost, inflation-adjusted costs, you can see that after 2004, there was a decade in which effectively your global sum payments did not change in real value based on, inflationary pressures. And then in 2014, we did start to see an uplift. Then income fell, and that's really tricky because that falling income was in a period where inflation, as applies to GP practices, was higher than general inflation. So obviously, inflationary costs with GP practices, we're not the nation, or inflationary costs across the whole nation cover all sorts of things. But you know that the costs to you running a GP practice, relatively narrow set of expenses, and the inflationary costs to those expenses, particularly employment expenses, really significant increase. And when you look at the expenses and earnings report, which we'll come to in a bit, you'll see that expenses continue to go up like that. And at a time of high GP practice inflation, the cost pressures associated with that fall in global sum is really, really difficult. And we absolutely recognise this, and that is clearly then what we sought to do from taking on the role of national negotiators in 2023-24 was to say, right, we have to focus on global sum, because however imperfect global sum is, we have to focus on increasing the core income to practices. It's that which keeps people afloat. And obviously, I'd like that line to be creeping up higher, but that's what we've done to global sum over the last 2 years. Okay, so I know you don't elect me, it's not a plea as a politician, but just saying to you, I wanted to explain, first of all, how complicated it is, and secondly, to show you what we've tried to do in terms of your primary source of income, which is global sum, based on its true value. Now, we have been caught out by the costs that have been associated with employing people. So it is difficult, but at least that graph has turned around the right way over the last couple of years. Right, I'm going to move on to some of the other things. Now, first of all, not everybody will have heard of Statement of Financial Entitlements, but it's absolutely essential for practice managers, business managers, to be on top of the SFE, and we really need you to claim everything you can from it. Now, the sort of substantial amounts that you can claim are parental, which covers all sorts of maternal, paternal, adoptive leave, and also sickness leave. And this covers both partners and salaried GPs. Now, one of the challenges is it doesn't cover anybody else. It only covers doctors. And we have tried to persuade NHS England that, you know, looking at the way practices operate, it's just as financially challenging to have other members of the team away as well as doctors. So we did focus on clinicians, particularly practice nurses, but they just wouldn't budge, and that is, you know, a high item in terms of our negotiating lists for 26-27. Now, obviously, parental leave, I've mentioned to you, there's quite a lot. You'll have seen the recent introduction of neonatal leave, and there's going to be leave associated with miscarriage as well. That will all be put into the SFE. And when the salaried GP contract is adjusted to take these costs into take these entitlements into account, the salaried GP contract always aligns with the leave periods in the Statement of Financial Entitlements. So what we do is make sure that even if things change for your salaried GP colleagues under their model contract, what you can claim isn't any longer than what's in the what you have to pay isn't any longer than what's in the SFE. Now, we also think that you need to look at your partnership agreements as well in relation to what leave claims you can make. Now, obviously, it's entirely up to you, you know, what you do in terms of your partnership agreements. That's a matter for you and your mutual discussion. But what we do think is you should make sure that what your partnership agreement says aligns with what you're able to claim from the SFE, and that means not just the amounts, but the type of leave that your practice manager will say, okay, you're going on adoptive leave, or you're going to be sick for a period of time. Do the items in your practice agreement align with what you can claim from the SFE? Now, there are some things you can't claim from the SFE, and, you know, picking up recent queries we've had in the office, you can't claim for jury absence. So we do think that partnerships will also want to think about insurance in relation to certain types of leave, if you can get it, because it's important to be aware that some reasons for partners being away or salaried doctors being away, if you want to cover them in their terms and conditions of employment. But thinking about partners, some reasons why partners might be away, you can't claim that from the SFE. And I mentioned that we want to extend this to other clinical staff, because obviously that has a big impact on the practice. Now, last year we were able to uplift the SFE entitlements by as if the DDRB awards for previous years had been applied, and this year the SFE uplift mirrored the DDRB award. But we remain sort of our negotiating strategy is to link the claims you can make with the pay uplifts that apply to the practice, and that's what we're trying to do. So obviously I've just given a couple of examples of the uplifted fees that you can claim, but just to flag up to you that every attempt is being made. Now, we know that the true costs of staff absence may be higher, and also there are intangible costs in terms of the disruption that people, that it happens when people are away. And obviously, people are entitled to go away, for example, on maternity leave and not feel anxious about what's going on back at the ranch. So, there is a disruptive element to people's absence that you can't, money doesn't cover, if you see what I mean. But the aim is to maximize the money you can get. Now, we know that it's not enough, but the SFE reimbursements have gone up very substantially over the last few years. And also, we've been really careful to ensure that changes in employment arrangements, like the recent introduction of neonatal leave, are reflected in the SFE, because there's no requirement for NHS England to do that, but there is a requirement for you as employers to reflect that in your employee arrangements. So that's where we are with SFE. Now, for salaried GPs, obviously, you get a DDRB recommendation and away you go. That changes the salary scale. Now, the BMA publishes a salary scale on its website, and the salary range is now 76 to 114. Now, it is absolutely fair of me to say that the sessional committee, the GP sessional committee at the BMA, does not consider the published salary range as high enough, and therefore they publish their own range as well. But I've only included the formal sort of DDRB linked salary range. Now, you don't have to pay that. You can pay what you like. But for most salaried colleagues, they will want a model BMA contract. And if they have a model BMA contract, then in that will be written an annual uplift linked to the DDRB recommended uplift. Now, that is part of an unmodified BMA model contract, and it's probably one of the clauses, along with CPD leave, entitlement to holiday leave. It's one of the clauses that you're going to find very difficult to negotiate out of a model contract. Now, you can negotiate the model contract differently. The only thing that it says in the regulations is that if the terms and conditions are varied, they should be no less favourable. There's no further definition of no less favourable, but it's unlikely that removing the link to the DDRB would be considered it would be considered less favourable than the model contract. Just to pick up a query, the SFE will send you, if we can find it during the presentation, one of my colleagues will put a link. The SFE is the Statement of Financial Entitlements is updated every year, and there is an NHS England link to the most recent version. So we'll try and find that for you. Now, if you're employing a salaried GP, there's lots of reasons. Oh, look at that. Oh, wow, I don't even need that. Thank you very much indeed. That's very kind of you. When you're negotiating salary, there's lots of things you'll think about, the sort of experiences, the expected responsibilities, but it is a harsh reality as well that salary will be based on economic circumstances, both in terms of the number of people who are available to take a job and the sort of economic circumstances of practice as well. There's no, you're a business, you're running a business. We obviously recommend that you employ colleagues under the BMA model contract, and if you do, then that includes a specific link to the DDRB recommendation. So to pick up a question here, that's absolutely right. The BMA model contract considers full-time to be 9 sessions, and it is perfectly legal to pay colleagues more than the range listed in the BMA, and we know for economic circumstances that some practices do and some practices don't. But if you, whatever your baseline is, if your GP colleague has a BMA model contract, you need to increase it by the DDRB recommendation if that's what's written in the model contract, and if that means that the salary rises above the range that's published on the BMA website, well, that's what you're entitled to do, and that's what your salaried colleague is entitled to say. So it is a really difficult environment at the moment. Sessional GPs obviously you know, are elected to press for their colleagues, but all of us recognise that the reason that these situations arise is because you are not adequately funded for the work you're expected to do. And the work you're expected to do has to be done by people you employ, as well as yourselves as partners. And so both the sessional committee and the GPC England committee are absolutely clear that the reason that people are having difficulties in terms of salary is because general practice isn't funded adequately for what we're being asked to do. So there isn't a piece of paper between us on that, but obviously there are sometimes challenges in terms of how you sort of employ somebody. Yeah. Now, there's been a couple of queries about on costs. If I go back to the global sum salary costs, which is this slide somewhere back here. Here we are. Other staff expenses. That's based on HMRC data. HMRC data on expenses that GP contractors pay. That includes on costs. Okay, so although there seems to be this urban myth in terms of the HMRC data on the expenses you have to pay, that includes the on costs for people you employ. So that is included within the global sum calculation. But as I've sort of explained, there are several sort of processes, I call them bumps in the road. There are several bumps in the road between what goes in and what comes out. And what comes out is not enough. Okay, even though we're trying to make it enough, and look at that graph, it is not enough. And part of that reason is because the inflationary pressures on practices are not really the national inflationary pressures, because inflationary pressures within the nation includes lots of costs that are completely irrelevant to general practice. But one of the inflationary pressures is staff costs and staff expenses, and that is significant for GP practices. So what we've said to the DDRB is it's no good just looking at the national inflation measures, which is what they do, you need to look at the inflationary pressures as they specifically apply to general practice. So no one is getting enough for what they need to do, but we're trying to make it as advantageous a financial model as we can. But we recognise that one of the problems is you're dealing with a Cahill formula that just doesn't allow us to do that. Right. Now, in terms of oh no, that's salary GPs. In terms of everybody else, now most staff apart from salary GPs, most staff employed in GP practices are not part of national negotiating agreements, which is a plus and a minus, because obviously that allows you as employers to be flexible, but it also means that staff may feel at a disadvantage, or there's no national benchmarking that allows you to say what people should be paid. Now, what that tends to mean is that the DDRB award is seen as the benchmark, and certain colleagues, for example, our nursing colleagues through the Royal College of Nursing, they were particularly vociferous on this point. How can I put it? Their eyes have been opened when we showed them what it meant, like I've just done in this presentation, between getting a percentage recommended uplift, and they had no idea about sort of global sum and the Cahill formula, and they, it was a revelation, I think. And they kind of realised that actually their sort of messaging about that's the percentage increase, so that's what you should pay, did not take into account any of those factors, and they now understand that. I mean, obviously perhaps they think we should all be salaried or whatever, but what they understand now is it's not just a simple matter of holding up a placard saying 6%. And I hope, because we did get quite a lot of concerns raised by practice managers about letters being sent to the RCN, by the RCN to practice nurse colleagues, I hope, or at least in terms of the information we're getting at the LMC office, that all seems to have sort of died down now, which is good. I mean, it's obviously really, really difficult because you want to pay people, a sort of a reasonable recompense for what they're doing, and we all work alongside these colleagues day by day, and yet your purse strings are constrained. And one of the reasons for sort of flagging, when we flagged it up to the RCN, it was to try and get people to realise that actually the financial environment for general practice is really, really difficult. And one of the other things is also the terms and conditions that you have access to, and that's another reason why we want to put at least clinicians, but ideally all practice staff, into the SFE, just like the negotiations many years ago now include practice staff with access to the NHS pension scheme. So that didn't used to happen, but it does happen now. So we managed to get the government to change its wording slightly. This time it still feels they should pay everybody, but the DDRB uplift, but they've not set that as a contractual requirement. Instead, they've kind of what you would probably call warm words in relation to doing that, but ultimately it remains a decision for you as an employer what you do with other practice staff. The other thing that practices are absolutely entitled to do is to say, right, well, we know there's going to be or they were this year, they were entitled to say, we know there's going to be a DDRB announcement later on in the financial year, so we can give you a moderate or minimal increase in April, and then wait and see what the final outcome of the DDRB is. And welcome. You're perfectly entitled to do that if you want. But what I'm hoping is that all of these complexities will be reduced a bit next year if the DDRB reports and the government accepts whatever is said by March. Then we should be able to get all the financial arrangements in. I can't promise April, but by May, your spreadsheet should show the 26-27 financial arrangements, and you'll know that it's not going to be changed later in the year. So just wanted to pick up on a couple of other points, probably most relevant to we've got PCN colleagues with us. There was an uplift within the additional roles allocation pod, and I alluded to it earlier on. Although you can't see GPs in ARRS as a separate claimable allocation now, that was uplifted as the equivalent of a full financial year's 4% uplift, but the other allocations were only increased by 0.8% because the addendum for change was 3.6 and the pay assumption built into what you're supposed to manage in terms of efficiencies was 3.6 and 2.8% pay assumption. Now, one of the things we decided to challenge this year was GPs employed under other arrangements than being employed by the practice. So if a GP who's paid by the ARRS scheme is employed by a practice, a member practice within the PCN, then they could be treated as a performer, and you could claim the SFE reimbursements if they went on holiday, they went on maternity leave or they went on sick leave. You could claim that just like all your other staff, if you employed salaried GPs, that you paid them directly, and then you had employed GPs who were paid via an ARRS claim previously. Then both of those you could claim under the SFE. The problem was ARRS GPs who were not employed by a practice. There was no facility in the SFE to allow those employers to claim under the SFE, because only practices can claim under the SFE. So we put all this to NHS England, and obviously NHS England, for various reasons, are quite wedded to the ARRS scheme, and we said there's a sort of gap in terms of employing GPs not at the practice, and they agreed with us, and they said that's fine, we will change the SFE and we will change the PCN DES so that if a GP paid for by the ARRS is employed by other third-party organisations, including incorporated PCNs, GP federations, even by trusts, basically they can claim under the SFE as well. Now, it's not a huge number of people, I absolutely appreciate that, but it was the principle behind it that we wanted to establish, which is that however GPs are employed, if they're working in general practice, which your ARRS GPs are, you should be entitled to access to the SFE reimbursements. Now, if you go into the updated PCN DES, I know this sounds a bit nerdy, but just go to Annex E, and there you will see it all written out. And the entitlements are exactly the same as the SFE entitlements, including the duration and the money, are exactly the same as applies to colleagues who are employed or working as partners in practices. So we do know that this is a bit of news for ICBs, and we do know that not all employers might be aware of this. So I wanted to flag this up. I have written out about it as well, I wanted to flag it up. If there are any difficulties with this, come back to us, come back to the LMC office, because this is unfamiliar territory. It's the first time that anyone other than a practice has been able to claim under the SFE, and that really sort of nicely sort of takes me on to the point that I made before. We are trying to extend the scope of the SFE to cover other roles as well, and this is progress in that direction. Now, in terms of what happens to ARRS in the future, which is a question that's just come up in the chat, we're obviously in a process of transition. I'm not going to sort of talk in depth about what's going on the national contract negotiations, but obviously with the announcement of the 10-year plan and single neighbourhood providers and multi-neighbourhood providers, there is a question mark over the PCN DES. NHS England is quite wedded to the PCN DES, but as you know, it's a sad goodbye to NHS England as a sort of separate organisation, although I'm sure lots of bits of it will reappear in different guises. And we want the ARRS budget to be associated with practices. Now, putting so those of you who can see the chat, you'll see the query, put the ARRS into global sum. Now, just listen to what I've said about global sum, sort of, 3 or 4 slides before. Putting things into global sum is good, but it doesn't get us quite where we need to get, because global sum is circumscribed by the Cahill formula. So just putting 1.4 billion into global sum might not achieve the result that we all want. And also, NHS England and the government might not say, oh yeah, that's a great idea, why didn't we think of that years ago. So what we're kind of thinking is that ARRS might be converted into a staff reimbursement scheme, and the advantage of that is that one of your biggest costs, frankly, is staff. And the volatility of staff expenses over the last couple of years, exemplified by the national insurance issues, but also by the changes in the minimum wage. That volatility has been really difficult for practices, because you've got your income, but you've got this volatility in terms of who you employ. And it also affects who you decide to, whether you expand your workforce or not, and can lead to some really difficult decisions. So we feel that it might be better to have a separate way of claiming for staff that work in your practice outside just paying for them all through your capitation income, through your global sum income. So I'm not sure that we would necessarily. I think if they came to us and said we'll put it all in global sum, and there were no alternatives, we'd probably say great, thank you very much. But you can see from this presentation that's not actually everything it's cracked up to be. So I think in terms of what happens with ARRS, it's all predicated on what happens with PCNs, and possibly what happens with the neighbourhood programmes, but that's not going to sort of happen all at once. There's a period of huge chaos and uncertainty at NHS England, and I think this is a good time to push. Now, for those of you who are old enough to remember, you will remember that there was a staff reimbursement scheme within the Red Book. And although this wouldn't be exactly the same, we have taken some of the ideas from the Red Book in terms of how can we build a staff reimbursement scheme for general practitioners that takes away some of the risks. And so that's our thinking about ARRS. Now, obviously, we don't know exactly how negotiations are going to go. But it was really interesting having this discussion about comparatively small number of GPs and NHS England accepting the principle of parity in terms of, what's available to the employers of GPs. That's expanded. Now, of course, there are other people who might want to employ GPs, but and that's a separate sort of issue. But in terms of staff reimbursement, that's what we're hoping to move towards. Not quite related to the ARS scheme, but there's a question about childhood immunisations and vaccinations in QOF, and absolutely. So I'm really sorry to burst your bubble, unknown GP, or so unnamed GP from West Sussex, who's just posted in the chat. We are absolutely we had a real go at them about QOF this year in terms of childhood vaccinations. We suggested that the QOF money attached to childhood vaccinations was transferred to the item of service fee. We got a bit of stick, if you remember, from transferring QOF money into Global Sun, but we feel that on balance, you probably accept that change and diminution of QOF value if it went into item of service fees. But there's always someone who doesn't agree. That this is life, and you've just got to try and get the best outcome for the best possible number of people. Right. Now, am I on the right page? Yes, I am. Here we are. So the earnings and expenses, it's a really interesting report, and it gives huge amount of detail. It does cover Scotland, Wales and Northern Ireland as well. My message to you is be a contractor in England in terms of your sort of average income based on this report. If you're a salary GP, things are a bit more nuanced, and the sort of differential between average income for salaried colleagues and contractor colleagues, the differential is narrower between the four nations. But you've got to have a good reason to move to well, just, let me just say it. You've got to have a good reason apart from salary to go and move to Wales. So if you look at the averages, you can break them down in terms of the contract type. So that's GMS or PMS. Obviously, remember, Wales and Scotland don't have PMS practices. And then if you look at the age, the gender, ethnicity, there's a really interesting set of graphs which demonstrate, some of the concerns that have been raised generally about the gender pay gap. There's also an interesting, if you look at the contractor graph, there's a cohort of contractors who are paid significantly above £250,000 after tax and expenses. So it shows you that people have different approaches to how they use the GMS contract or PMS contract in terms of the income that they achieve. However, I'll let you go onto the website and look at that. The important thing is that is used by NHS England and by the DHSC in terms of contract negotiations, and by the DDRB when they're considering their annual recommendations as well. Now here's some graphs. Now obviously if we look at contractor income before tax, obviously we all have to pay tax, or at least if you're not paying tax, keep it quiet. Now obviously what we need to do is to look at what's happening to contractor income in real terms, in real value. One of the problems is, and I've alluded to it, is that there are different ways of measuring inflation. There are lots of different markers for inflation, and so it depends which one you choose. A couple of colleagues have mentioned the sort of impact that COVID had in terms of skewing income and expenses. And look at that graph. But overall, the challenge for all of us is that there's not been a substantive and sustained increase in contractor income before tax for the last 20 years. Okay, and I know that you'll recognise that, and it's a real challenge for general practice. I think we should be careful in the chat. I mean, obviously, publicly available public information is fine. I've got no issues about putting that in. Now, remember, this is contractor income. Okay, so you're not feeling very happy. This is salaried GP income before tax as well. And this is why our salaried colleagues are feeling quite challenged as well. This is based on HMRC data just as much as it is for contractor data. And so what I was alluding to earlier on is that all of us recognise that there isn't enough money in general practice being paid into general practice to deliver the workload and the workforce that we want. Okay, and that is exemplified for me by these graphs, which is one reason why I put them up. So as you can all see that however much we try, and everyone sort of gives lip service to the value of general practice, but if we don't have enough income going into it, well, these two figures refer to GP workforce payment. But if you look at the whole global thing about delivering care and services to patients, and it's not just workforce, but a substantial part of it is, then we're just not putting enough money into general practice. Now, I'm not going to get into a debate in this webinar about, well, could you ever put enough money into general practice if it's all derived from the state? That's another sort of discussion. But it just emphasises the challenge. Now, in fact, there are other graphs which look at our consultant SAS resident doctors, used to be called juniors, but now they're called residents. If you look at those graphs as well, you can see the challenge in terms of paying for the NHS, whose most substantive bill is staff. Right. The last thing I just wanted to remind colleagues is about pensions and other sort of I've put in a sort of final bit. So basically, we do not believe there are going to be any changes to the current arrangements. I know I had a number of practice manager colleagues get in touch to say, well, if we have to fund the 6.3% that's currently now centrally funded, we might as well just lock up and go home. And absolutely. So there is, just to reassure you, that there is no expectation that this arrangement whereby central government pays 6.3% of the pension payments directly, you don't see it. There's no anticipation that that's going to change at all. So just to reassure you. Now, we've talked about national insurance. Now, I do not know, I've got to break it to you guys, I don't know what's going to be in the budget. Okay. So I've no idea what national insurance is going to look like in terms of any possible changes. And if anybody does know, please sort of tell us all. But you can predict what's going to happen to the national living wage. The Low Pay Commission will recommend changes to the government next month. And if you go on their website, you will see that is what they reckon they're going to be recommending to government. So you can factor that into your sort of financial. I understand it's usually a sort of accurate prediction. That's what we reckon is going to be the impact. Now, I completely understand that affects different practices in different ways, depending on the sort of number of staff you employ and their age. But that's the recommendation. Right. So I think. Yes, just to remind you of your secretariat, the LMC office up here, and thanks to all colleagues. Several colleagues were involved in sort of ensuring this webinar worked. Now I have tried to pick up some of the questions that have been picked up. What I will probably do is we'll look at the questions within the chat when we finish, and then send out. The recording will be available. Yes, absolutely. The recording will be available, and the slides will be available, and then we'll do an update based on the questions and try and link those with the guidance letters that have already come out. So in terms of that, we finished early. I am delighted to see. So in terms of what happens next, I know that a lot of you will be thinking about next week. I'm hoping that the guidance that we've produced in the form of FAQs is being sent out, will be available to practices this afternoon. I know there'll be a lot of queries, and there's also a lot of liaison that we need to have with our ICB. So haven't been able. That's brilliant. Thank you. Thanks, Jacqueline. I won't be able to ask or answer all questions that colleagues may have in those FAQs in one go, but I know that there are a lot of concerns and queries, so I've tried to cover as much as possible, and as much as we understand it from now, in terms of whether you'll need to make any changes or not. I realised as I was writing it that there will be sort of version 2 coming out hopefully in the next week or so in terms of further queries that relate to the online consultation changes. Great. Right. I don't know. Where are you, Sarah?
I'm here. Julius, would you like me to stop the recording?
I think it's probably time to finish this webinar for now.
Wonderful. Well, thank you very much for providing all that advice and guidance, Julius, and it will be sent out as quickly as possible today.
Right, thanks very much, everyone, and I hope that was informative.